Imagine looking at a diagnostic scan of a massive, painful swelling deep in a patient's tissue.
Right.
You drain the site, and out pours this really thick, white fluid. I mean, every medical instinct you have screams that this is a severe bacterial infection.
Oh, absolutely. It looks exactly like one.
But what if you run the lab cultures, and every single test comes back totally negative?
Yeah, that's where things get really complicated.
Exactly. So today's deep dive is about a biological imposter. We are taking a stack of clinical case studies and research papers to explore a highly deceptive clinical puzzle for you today.
It's a fascinating puzzle, honestly.
It really is. Picture a patient presenting with a swollen submucosal mass in an anterior wall. Now, this could be the anterior wall of the gastric antrum, like in
Yeah.
the stomach,
Right.
or it could be the anterior vaginal wall following a cosmetic or a functional procedure. On the surface, the presentations look incredibly similar.
They do, yeah.
The massive question for you as a clinician is this. How do you know if you are looking at a dangerous, potentially lethal bacterial infection that could lead to sepsis? Or, a bizarre, highly reactive, completely sterile abscess caused by an injected filler?
Well, the stakes in this specific diagnostic window, they just couldn't be higher.
Yeah.
Treating a sterile immune reaction as a standard infection exposes the patient to unnecessary antibiotics, and it leaves the underlying immune cascade just raging.
Right. You're not actually fixing the problem.
Exactly. And conversely, treating a hidden atypical infection as a mere allergic response, that can trigger catastrophic systemic complications.
So our mission today is to equip you with the diagnostic framework and the exact treatment protocols to differentiate and effectively treat sterile submucosal abscesses versus infected deposits.
Yes.
We have to start right at the point of presentation, though, to understand why the visual similarities of these masses are so incredibly deceptive.
Right, because they really trick you at first glance.
They do. So looking at the stomach first, a patient with an infected submucosal abscess in the anterior wall of the gastric antrum, they're going to present with intense epigastric pain, vomiting, and anorexia.
And just to clarify, that means a complete clinical loss of appetite, not the psychiatric condition.
Ah, right. Good distinction. So systemically, their body is flashing these massive warning signs, like high white blood cell counts and elevated CRP, signaling severe systemic inflammation.
But the physical examination alone isn't enough, because the mucosa on top of the abscess often looks perfectly intact.
Which is wild.
It is. You have to use advanced diagnostic imaging, specifically endoscopic ultrasonography, or EUS, and a CT scan.
Okay.
When you look at the EUS, you typically see a localized hypochoic mass with mixed echogenicity, and it's trapped deep in the third layer of the gastric wall.
Wait, when you say a hypochoic mass with mixed echogenicity, you just mean how it looks on the ultrasound screen, right? Like the fluid inside is bouncing the sound waves back in a chaotic way.
Yes, exactly that. The fluid and tissue have different densities.
Okay, got it.
So that chaotic bounce back of those sound waves tells you that you aren't just looking at solid muscle. You are actually seeing liquefied necrotic materials and an air fluid level physically trapped beneath the lining of the stomach.
Wow. And when you aspirate that gastric abscess, you get true foul-smelling, purulent fluid.
You do.
In one of our source cases, the culture of that fluid yielded Candida albicans and this incredibly rare pathogen called Elizabeth Kingia anopheles.
Yeah, that case is wild.
It is. This is a bacteria originally isolated from the midgut of a mosquito, and it happens to have natural resistance to a terrifying number of antibiotics.
It's a real nightmare to treat.
I have to stop you there, though.
Yeah.
A pathogen from a mosquito's gut.
Yeah.
How does that even get into the third layer of a human stomach wall?
I know, it sounds like complete science fiction.
Yeah.
But Elizabeth Kingia anopheles is actually an opportunistic environmental organism.
Okay.
It can be found in soil and standing water. So if a patient swallows contaminated water or food and they happen to have a microscopic tear or a microabrasion in their gastric mucosa.
Like from swallowing a rough piece of food.
Yeah, exactly. Or maybe from an underlying ulcer. That bacteria can slip right through the surface layer.
Oh, wow.
And once it gets into the deep submucosal plane, it finds this warm, protected environment, colonizes, and builds a massive infection.
That is just wild. Now, contrast that angry, infected gastric mass with the sterile pseudoabscess in the anterior vaginal wall.
Right. Totally different scenario.
Yeah, this frequently happens after a patient receives periurethral injections of bulking agents. For example, bovine glutaraldehyde cross-linked collagen.
Which is used to treat stress, urinary incontinence.
Exactly. So 6 weeks after a totally uneventful procedure, the patient presents with extreme tenderness, obstructive symptoms, and straining to void.
It feels exactly like a raging infection.
It really does. But the urinalysis and the standard cultures come back completely negative, and the physical extraction findings diverge completely from the stomach case. Because if you drain that periurethral mass, you don't get foul pus. You get this non-odoriferous, highly viscous fluid that literally looks like toothpaste.
Yeah, toothpaste is the perfect description. It's a massive accumulation of fluid, but absolutely no bacteria.
Right.
Which is why we use the term pseudo-abscess. Biologically, I mean, a true abscess implies a collection of pus driven by pyogenic pus-producing bacteria.
Okay, so what is it then?
What you're seeing with these bulking agents is an overwhelming immune reaction. Clinically, however, the intense pressure this fluid accumulation exerts on the surrounding tissues causes the exact same pain profile.
Oh, I see.
It causes the same fluctuant swelling, meaning it feels like a fluid-filled water balloon under the skin, and the same obstructive symptoms as a bacterial infection.
Because the physical pressure on the patient's nerves doesn't care if the fluid is sterile or infected.
Exactly. Pressure is pressure.
It's like hearing the fire alarm blaring in your house, you know?
Yeah.
You have to figure out, is there an actual fire burning in the kitchen, like an infection? Or is the alarm system itself just short-circuiting and panicking over nothing, flooding the house with sprinklers for no reason?
That's a great analogy.
Both cause immense damage, but they require totally different solutions.
And direct fluid aspiration, along with advanced imaging, are the only ways to confirm whether there is an actual fire.
Right.
You absolutely cannot diagnose these by touch or sight alone.
So we've established that aspiration is mandatory. But what happens when you drain the fluid, you send it to the hospital lab, and the standard cultures come back completely negative?
Well, that's where things get tricky.
Right, because you might think the alarm system is just short-circuiting, but it's actually harboring a phantom infection.
This is a massive, massive diagnostic pitfall.
Tell me about it.
When dermal fillers, like HA, are injected into the submucosal or subcutaneous planes, the needle or cannula physically punctures the tissue, right? It creates microtrauma pathways.
Like tiny tunnels.
Exactly. Tiny tunnels that bypass the body's external defenses. They can introduce environmental organisms directly into the deep tissue, right alongside a foreign biomaterial that the bacteria can use as an anchor.
And some of these environmental organisms are practically invisible to standard tests.
Very true.
Like nocardia nova is a prime example. In one of our source cases, a patient developed these persistent delayed onset nodules 11 months after receiving HA filler along her jawline.
11 months later.
Yeah, they presented as cold abscesses. So they were soft and fluctuant, but they completely lacked the severe heat, redness, or spontaneous discharge you expect from an acute infection.
And standard hospital testing misses nocardia almost every single time. Even standard acid-fast staining often fails.
Why is that?
Well, acid-fast stains are designed to bind to specific lipid-rich cell walls like you see in tuberculosis. But nocardia only weakly possesses those specific lipids, so the dye just washes right off.
Oh, wow. So how do you find it?
To actually find it, you have to suspect it clinically and order a highly specific culture on Lowenstein-Jensen medium.
The threat extends beyond just environmental pathogens, too. We also have to hunt down biofilms.
Yes, biofilms are awful.
These are frequently caused by very common, slow-growing skin flora like Staphylococcus epidermidis or Cutibacterium acnes, and traditional fluid cultures miss them completely.
Right, because the bacteria aren't floating freely in the aspirated liquid. They have physically bound themselves to the foreign filler material.
Which is terrifying.
The mechanism of how they hide is fascinating, though. Once they attach to the HA filler, they secrete an extracellular polymeric substance like a thick, slimy matrix.
Gross.
Very. They essentially build a microscopic fortress. And this matrix protects them from the host's immune cells and from standard antibiotics.
Wait, hold on. If I'm a clinician and my patient has a delayed painful nodule and I run a standard lab culture that comes back completely negative, well, my first instinct, and I bet the instinct of a lot of practitioners, is to assume it's just a sterile allergic reaction to the filler.
Sure, that makes sense on the surface.
Right. So why can't I just dissolve the filler with an enzyme and hit them with a heavy dose of steroids to calm the swelling down?
Because that specific instinct carries a catastrophic risk.
Really?
Yes.
Right.
If you administer corticosteroids to a hidden nocardia or biofilm infection, you are actively suppressing the local immune system.
Oh, you're turning off the body's guards.
Exactly. Because the bacteria are shielded by their matrix, or by the slow-growing nature of nocardia, they suddenly have unchecked freedom to replicate.
Oh, no.
Yeah, this allows the atypical infection to spread deeper, far more aggressively, potentially causing severe tissue necrosis or even systemic dissemination.
So treating the false alarm with steroids when there's actually a stealthy fire burning just pours gasoline on the flame.
It really does.
You have to rule out these phantom infections using advanced diagnostics first, like molecular studies. Running PCR, or a FISH assay, can detect the bacterial DNA even when the bacteria refuse to grow in a petri dish.
Absolutely.
And if you do find them, the treatment is totally different from handing a patient a standard Z-Pak, right?
Entirely different.
Nocardia requires prolonged, highly specific therapy, often trimethoprim sulfamethoxazole, for months. And for biofilms, our sources highlight the need for macrolide antibiotics, like clarithromycin.
Right, and macrolides are chosen for a very specific mechanical reason.
Which is?
Because biofilms are incredibly resilient, it takes exponentially higher concentrations of antibiotics to penetrate that protective matrix. Macrolides, like clarithromycin, are highly lipid-soluble, meaning they actively accumulate in subcutaneous fat and tissue.
Oh, so they go right to the source.
Exactly.
Yeah.
They concentrate right where the filler and the biofilm fortress are located. Maintaining that therapy for up to 6 weeks is often the only way to ensure the matrix is breached and the bacteria are eradicated.
Okay, so we've mapped out how to hunt down these invisible bacteria. But what happens when you do all that molecular sleuthing right? You run the PCR tests, and you prove beyond a shadow of a doubt that there really is no bacteria at all.
That it's purely sterile.
Yeah. The mass is conclusively a true 100% sterile abscess caused by a hyaluronic acid filler. It's purely an immune overreaction, but it simply won't go away.
Well, this is an escalating problem with modern, highly cohesive fillers like Juvederm Volux.
Right.
This product is a tightly cross-linked HA designed to mimic bone for jawline and chin contouring. Cross-linking physically weaves the individual hyaluronic acid strands into a really dense, unbreakable three-dimensional net.
So it's tough on purpose.
Exactly. It is engineered specifically to resist being broken down by the body, so the cosmetic result lasts longer.
But the body's immune system doesn't see a cosmetic enhancement. It sees a massive, indestructible foreign invader.
Right.
So macrophages rush to the site, attack the net, and fail to break it down.
Yeah.
They recruit more and more immune cells, creating this fierce inflammatory cascade.
And the patients look incredibly sick when this happens.
I can imagine. They present with high systemic inflammatory markers, like elevated ESR and CRP. When you aspirate the site, you get a purulent, gelatinous exudate. It looks like thick pus, but again, absolutely zero bacterial growth.
The sheer power of the innate immune system is on full display here.
It's kind of amazing.
It is. An intense immune-mediated reaction to a completely sterile agent produces true purulent material simply through the sheer volume of exhausted white blood cells and inflammatory fluid.
Wow.
For these recalcitrant cases, simple drainage or just a standard shot of hyaluronase isn't enough. The inflammation just walls the area off and the sterile abscess reoccurs.
Which led to the specific treatment breakthrough detailed in our sources.
Yeah.
The Munhas-Cavalieri lavage protocol.
Yes, exactly.
The mechanics of this protocol are brilliant. It's a precise chemical cocktail injected directly into the fluid collection, guided by ultrasound, so you were targeting the exact center of the mass.
And the recipe is very specific.
It is. It calls for mixing 4,500 to 6,000 UI of hyaluronidase, which is a massive dose diluted in 1 milliliter of saline.
Right.
To that, you add 3 milliliters of normal saline, 3 milliliters of lidocaine, and 1 milliliter of corticosteroid at 20 milliliter of dense. Every single ingredient has a specific biological job.
Let's break those down. The high-dose hyaluronidase is the demolition crew.
Okay.
Its enzymatic action physically cleaves the glycosidic bonds of that dense, cross-linked HA net, destroying the structural integrity of the root cause.
Makes sense.
Then the added saline serves to flush and dilute the viscous gelatinous exudate so it can be broken up.
What about the lidocaine?
The lidocaine stabilizes the nerve endings. It manages the acute pain caused by the internal pressure and the chemical reaction.
And the corticosteroid is the diplomat. It steps in to halt the macrophage cascade, effectively talking the overreacting immune system off the ledge and shutting down the production of the sterile pus.
Perfect way to describe it. Because the cross-linked filler is so dense and the immune reaction creates such a fortified walled-off capsule around it, multiple lavages are often required.
Right. You can't just do it once.
No, you generally space them at least a week apart to chip away at the mass. This targeted multi-agent chemical demolition prevents the need for disfiguring surgical excision in the middle of a patient's face.
Which is obviously a huge relief for the patient.
Definitely.
So chemical lavages work beautifully for accessible HA filler reactions. But some anterior wall abscesses, whether they're sterile or infected, are too deep, or they're caused by non-dissolvable materials.
Right.
They demand mechanical demolition. How does a clinician physically navigate and drain these delicate submucosal spaces without destroying the organ itself?
Well, looking back at the anterior wall of the gastric or esophageal tract, the gold standard has become endoscopic submucosal dissection, or ESD.
ESD, okay.
Historically, treating a deep gastric abscess might have required a partial gastrectomy, where a surgeon literally removes part of the patient's stomach.
Yikes.
Today, we perform the entire procedure from the inside through an endoscope.
The physics required to do this safely are fascinating, honestly. To perform an ESD, the endoscopist injects a solution, usually containing a blue dye called indigo carmine, or an epinephrine and saline mix directly underneath the mucosa.
And by injecting that fluid underneath the mucosa, the clinician is essentially hydroplaning the top layer of tissue off the muscle layer below it.
Oh, wow.
It creates a physical waterbed. This safety cushion visually and physically separates the delicate top lining from the deep muscle, protecting the stomach wall from the scalpel.
And the blue dye.
The indigo carmine acts as a blueprint dye. It starkly highlights the distinct tissue layers so the clinician knows exactly how deep they are cutting.
Once that waterbed is established, they use a specialized microscopic scalpel, like an H-knife or a 1.5 millimeter ESD knife, to make a highly precise 1.5 centimeter incision directly into the bulge.
Right.
As soon as the pocket is breached, the fluid is released. They use an endocap or an ERCP catheter to deeply aspirate the thick fluid, followed by a vigorous 20 milliliter normal saline irrigation to power wash the entire cavity.
And the incredible advantage of ESD is that it doesn't just drain fluid.
What else does it do?
If the abscess was caused by a physical foreign body, such as a migrating fishbone that pierced the esophagus and buried itself in the submucosa.
Ugh, that sounds awful.
It happens. The clinician can use tiny forceps during the ESD to reach into the cavity and retrieve the instigating object, turning what used to be major open surgery into a minimally invasive day procedure.
That is incredible. Moving from the stomach back to the anterior vaginal wall, treating that periurethral pseudoabscess we discussed earlier, the mechanical approach requires a different kind of architectural preservation.
Right, totally different tissue structure.
Yeah, the surgeon makes a specific inverted U incision. And this shape isn't arbitrary. It carefully preserves the periurethral fascia, which is structurally vital for keeping the urethra supported.
Very important step.
Once that flap is lifted, they make a simple longitudinal incision directly into the pseudoabscess for complete drainage.
Mechanical drainage can sometimes be shockingly simple if you understand the exact material you are dealing with, too.
How so?
Well, the literature describes a severe cosmetic complication where a patient had 12 milliliters of HA injected into her labia majora for cosmetic augmentation.
Okay.
Months later, the filler clumped into massive lumps that mimicked, according to the medical literature, bilateral vulvar testicles.
Oh my goodness.
Yeah.
A deeply distressing situation for the patient, functionally and cosmetically.
Absolutely. But because the clinician recognized it was isolated HA filler that had simply pooled and encapsulated within the tissue, they avoided making a massive surgical incision.
Oh, that's good.
Yeah, they resolved it by puncturing the lumps with an 18-gauge needle and manually squeezing the HA out.
Regardless of the method, though, there is a common theme across all these sources. Whether you are doing an ESD in the stomach, an inverted U incision in the vaginal wall, or puncturing a dermal lump, the protocol is to leave the site open for continued drainage. As a layperson, my immediate instinct is to stitch a wound completely closed so it heals perfectly. Why resist the urge to stitch the tissue back together?
It is a counterintuitive but fundamental rule of abscess management. It's called healing by secondary intention.
Secondary intention, okay.
If you surgically drain a cavity and immediately stitch the top closed, which we call primary closure, you have essentially rebuilt the roof over a flooded basement.
Oh, I see.
You will inevitably trap residual microscopic bacteria or highly reactive inflammatory fluids inside the pocket.
Because the skin or mucosa heals over the top much faster than the deep tissue heals from the inside out.
Exactly. The pressure just starts building all over again. By leaving the incision open, the cavity is forced to granulate.
What does that mean, to granulate?
It has to fill in with new, healthy tissue from the deepest part of the wound up to the surface. This open pathway allows continuous drainage of any remaining fluid and prevents the cavity from reforming.
Makes total sense.
Premature closure practically guarantees a recurrent abscess.
So we started with the deceptive nature of submucosal masses in anterior walls. The core lesson threaded through all of this clinical data is absolute vigilance.
Without a doubt.
You can never assume an abscess is sterile just because a standard hospital culture comes back negative. You have to hunt for phantom infections.
Right. You have to look for nocardia and biofilms that build those microscopic fortresses.
Exactly. The ones that demand specialized molecular testing and entirely different lipid-soluble antibiotic therapies.
Because if you blindly administer corticosteroids to what you assume is a sterile reaction, you turn off the body's alarm system and risk a catastrophic spread of hidden bacteria.
But once sterility is definitively confirmed by PCR or EESH, we have incredible tools. Protocols like the Munhoz-Cavalieri chemical lavage serve as a biological hazmat team, utilizing hyaluronidase to dismantle the physical net of the filler, and steroids to calm the immune cascade.
And for deep structural fluid collections, whether it's an angry bacterial pocket in the stomach or an obstructive pseudo-abscess in the vaginal wall, precision techniques allow clinicians to safely demolish the problem.
Like endoscopic submucosal dissection and targeted inverted U incision.
Exactly. By utilizing the waterbed effect of submucosal injections, they preserve the healthy tissue around the site, and allowing the wound to heal by secondary intention ensures the physical fire is actually extinguished, not just covered up to burn again.
The clinical data highlights how much our medical interventions are blurring the lines between infection and immunity. We are placing increasingly complex, highly engineered materials into the human body, and the body is responding with incredible, sometimes baffling intensity.
It really is. We're asking a lot of our immune systems these days.
Which leaves us with a fascinating, slightly provocative thought to end on for you today. As we continue to develop these tightly cross-linked biomaterials for both functional and aesthetic procedures, materials engineered with the specific goal of resisting the body's natural breakdown processes, are we fundamentally outpacing our own immune system's ability to recognize what is a helpful medical implant and what is a dangerous foreign invader?
That is the million-dollar question.
It is. Will the future of medicine require us to pre-program dermal fillers and surgical bulking agents with localized immune modulators? Essentially, will we have to build the diplomat directly into the filler's molecular structure to prevent the body from building these sterile, purulent abscesses in the first place?
It's entirely possible.
We've learned how to drain the muddy waters and dismantle the biological panic attacks, but perhaps the next step in biomaterial engineering is learning how to stop the storm before it even starts. Thank you for joining us on this big dive. We'll see you next time.